We have Dr. Richard Ford here. And Dr. Richard Ford is an emeritus professor of medicine at the North Carolina State University. And he is a co-author of both the AHA canine vaccination guidelines and the AAFP feline vaccination guidelines. Today's presentation centers on using antibody titers in practice to assess immunity.
It turns out there are some changes going on that have influenced veterinarians' interest in doing antibody titers in practice. And that, combined with the fact that the technology has actually improved, has had a very interesting impact on how we're looking at these things, how we're assessing that. So my focus this morning is to look at how titers, how antibody titers, how the technology plays out in clinical practice. Let me, by way of background, give you a little insight on what's happened here. What I've got listed on this is kind of the nidus wherein all of this titer issue began to surface. Now, I've been writing AHA and AAFP vaccination guidelines since they began. In the last, I'd say probably almost 10 years, these tests have been evolving in veterinary medicine. And VacciCheck, which is developed out of Israel by Biogal, has an interesting, we've been watching this for some time now, allows you to do point-of-care testing for antibody for the cat and the dog. That's somewhat novel. And you can obtain quickly in your practice titers for distemper, parvo, adenovirus, panleuk, herpes, and caleci. The results are reported in a semi-quantitative way. In other words, you get a high positive, low positive, and negatives. And so they give you this spectrum of range of positivity as well as negatives. The titer check, the other, the other in-house point-of-care test that's available is canine only for distemper and parvovirus. And this test provides qualitative assessment in the result reporting, which is you got it or you don't have antibody, plus minus. So that's what's on the market today. We've been looking at these, and I will tell you that independently, various universities outside and inside the United States have looked at these assays and tried to assess the sensitivity, specificity of these tests and have published that. And what's impressive is that they are high. Antibody titers versus vaccination. What are the in-practice applications of the technology today? This, I think, is very important and highly relevant to what we're doing. Very important point. We know, I think you do too, the number one reason for vaccination failure is maternal antibody. A point I made yesterday in the seminar, and I want to reiterate that today, is that you must leave here knowing that vaccination does not equal immunization. Very important point, very fundamental, sometimes hard to communicate to the client who takes that, oh, I got the shot and we're off to PetSmart. Not necessarily a good idea. So this dog is not immunized. What we have found with the high-titered vaccines that you are all using today is the mom titers are higher, and it is neutralizing or interfering later in life. And we are now recommending absolutely, and you should all be doing, a third dose out here around 16 weeks to ensure that we get immunity. But do we? We are concerned, ladies and gentlemen, this is a point you got to leave here with. In several locations in the United States, we have been collecting information for about 2-3 years now on this, that apparently some of these dogs out here have enough parvovirus maternal antibody to neutralize vaccine virus later and later and later. And we don't know in these patients whether it's moving out this way or they're actually responding to that dose at 16 weeks of age. This is something that is evolving. Keep your ear to the wall on this. But I want to remind you all that there is a threshold here. That yellow line that I just drew is the level, the threshold of protective immunity. So antibody, maternal antibody, above that line will protect against distemper or parvo and adenovirus. And the vaccine-induced antibody above the line will protect against distemper, parvo, antibody, as long as they responded to the vaccine. But if they did this, we don't know. So what we've got here is this big window of susceptibility. This is the don't go to PetSmart yet window. Because the dog, we know, very important point, very low, we don't know how low, very low concentrations of maternal antibody can interfere with vaccine below the protective threshold. So the dog has interfering amounts of antibody, but not protective amounts of antibody. So this is a big window of susceptibility here. And in some dogs it can last 7, 8, even as long as 10 weeks. And the question is, what happened after vaccination? I want you to know that one of the principal applications of point-of-care testing for antibody is to look at this here. About 2 to 4 weeks after the last dose of vaccine, in a patient that you feel might have risk for exposure, or the client is concerned, then you should do that. If the test is negative, this dog should be revaccinated. Parvovirus is critical. We are concerned. We have a lot of so-called breaks in parvovirus. So if they are negative 2 to 4 weeks later, at this point, you're out around 20 weeks, we would absolutely advocate a booster dose at that point. Now, there's another reason vaccines fail. As I give vaccine lectures, veterinarians say, well, what's your protocol for Dobermans and Rottweilers? We are seeing certain breeds, lines within breeds, that are not responding to parvo vaccine. We thought, well, we can fix that. We'll give them more vaccine. Turns out, these pit bulls, does that sound familiar to some of you? We are seeing a number of breeds that selectively seem not to respond well to vaccine. American Pit Bull is really at the top of that list. This is all anecdotal. We just don't have the data on it. But the fact is, these animals appear to be genetically programmed not to respond. These are so-called genetic non-responders. Giving them more vaccine will not drive immunity. So you're simply not able to get there with that one. So with canine parvovirus, we've got an estimated about 1 in 1,000 dogs. This is what we preach through the guidelines. And about 1 in 5,000 dogs, much lower number, are genetic non-responders to canine distemper. This is where I think you have the opportunity to provide a better insight on your patient. Did it respond or did it not respond by doing the post-vaccination titer? Another opportunity is the dog or the cat, puppy or kitten that presents to you with an unknown history. This, I think, is also a valuable tool, particularly where they might be introduced into a population with other pets. And you can tell quickly whether or not they have been vaccinated or exposed because they've responded with an antibody to the exposure or to vaccination. But it gives you an idea as to whether or not they are protected. And that's the leverage that we have that we didn't have earlier. Another application that I think has become important, in the AHA vaccine guidelines, we have made it very clear in a section that I developed for the guidelines on vaccine adverse events. We are concerned about dogs that do develop autoimmune disease, hemolytic anemia, thrombocytopenia, and the impact that vaccination might have on reactivating this. We're talking about the Cocker Spaniel that you treated last year for hemolytic anemia, and he's back for vaccinations. I'd suggest you might not want to vaccinate that dog. For the concern that the vaccine, which is a pretty potent immunologic stimulation to that animal, may reactivate thrombocytopenia or hemolytic anemia. We have very little data on this, but the fact is those are the recommendations, and we have published. We don't recommend vaccinating the dog. What we do recommend is do a titer. At least you know then they have made antibody. So what is the titer telling you in this patient? The memory is there. Next year the titer may go away, but the memory is there. I've got that documented. That's very important. Another side of this that has become very, very important and very applicable is in outbreak management. Shelters are understaffed, underpaid, and underloved. And I'll tell you, they're facing some real obstacles. They don't prevent infectious disease. All they can do, if you've ever done shelter medicine, is manage infectious disease. Point of care antibody testing is a critical value for that shelter that I showed you in Nevada. In other words, to go in and do the assessments. Well, these animals all have a positive titer for parvovirus. We don't need to euthanize them. They're safe. Leave them where they are. We don't need to isolate them. They've got immunity. Now, these two over here don't have antibody. They are susceptible, and they're the at-risk population. Let's segregate those and try and mitigate the disease in them. But this business of going in and mass killing all of the animals, depopulating the shelter because we think they're all going to get parvo or distemper is totally unnecessary. So that's kind of a quick and dirty. I think the manuscript that you should have picked up will give you some more details on each of these applications, but I hope that gives you a little bit of insight on how to use that. So ladies and gentlemen, thank you very much. I'll take questions up at the front.